Next, Dr. Umesh will be speaking on postoperative refractive surprise.
Yeah, thank you, Professor Vanati. It was her talk. I'm sure all of us have faced this. Very common for us. Most of us have seen postoperative surprises. And so most of us, when we do monofocal, easy to manage. Usually it is plus 1 or minus up to 2. It is easy to manage, especially if it is the minus side. Patients also don't complain because they have very good near vision, so most of them don't complain. The problem occurs is once you cross the 2 diopter, 3 diopter range, especially if you are on the hyperopic side. That is when the patients create much of an issue. So, though very uncommon nowadays with the advance of good biometries, source biometries and all those things, we do see across. And those who are practicing premium IOLs, especially Torics, though up to 1 diopter is acceptable, 92% plus minus, in the higher power of, if you are operating on the higher power of Toric IOLs, leftover of 1 is acceptable. Most of them are okay. Out of 4, if 1 is leftover, you don't mind. But if you are operating only on 2 diopters, 1.5 diopter, that is when the problem occurs. Then what shall we do there? So obviously you have to look at the detailed history, especially if you're going, if the patient, you have put a multifocal, ask for visual complaints like clarity, halos and glare. And if there is a overcorrection, undercorrection with intense glare, halos, if it's a multifocal, I think it's better you explant it. You look for manifest refraction, intermediate and near, complete slit lamp obviously. That is for to make sure that you don't have a problem in multifocal lenses. Monofocal lens, what are the options available? Yes, spectacles, contact lens, most of the older people don't do, that's an option available, but at least I try maximum myself to ensure that they are happy with the spectacles up to 2-3 diopters. If it is on the minus side, I somehow manage to counsel them and say them it's good for you, your reading is good, blah blah blah. Most of them are convinced. Those who are not convinced, I have a couple of options. One is either IOL exchange or a corneal refractive surgery, that is for monofocals. Multifocal IOLs, invariably dioptics was seen in the past. That is, if you have any correction, do a refractive surgery. But if the patient is not happy, the IOL exchange is the only option for multifocal. Though nowadays with the advent of the newer EDOF lenses and all, the incidence has come down. But in the older days, we did have a couple of cases where we had to do some explantations. Toric IOLs, yes, very common. 3.3 for every degree of misalignment, you will get 3.3% of the intended correction loss. So more than 30 degrees, everything is lost. So you have to do that. We'll go one by one. If it is a toric IOL, what we do is, within earlier the better. We have online calculators for that, both astigmatifix.com and Barrett transform formulae. You just have to go to the online calculator and put, you will get the readings. You have to do that. A simple off trick is, what I do is, third day or first week post-op, see if there is significant change in the intended axis. I just do a AK and see what is the steep axis and rotate it on the steep axis. Most of it will be done. And invariably, that and the astigmatic outcome, what it recommends more or less will be the same. That is what I have observed. 1 degree this way, that way, a couple of degrees this way, that way. But as a personal experience, you can take a call. Invariably, they all do very well. This is one such case where I had a -3 post-operatively. It was supposed to put at 167 degrees. This was the chart I got from the company. We went ahead and put post-op. I had -2 residual. -3 is the cylinder. I got -2. The IOL rotated around 16 degrees. 16 degrees. So the intended was 166. We went and did a toric lens. It gave the same thing, around 16 degrees. The axis also post-op AK showed 167, so 170 degrees, so more or less there. We went and did a re-rotation, and post-op cylinder we got 66. So it's relatively easier for us to handle post-op toric IOLs because we have these new formulas. In IOL exchange, we do when we mainly the main is wrong IOL power insertion, and that invariably happens many times. I think Arup has done an extremely good job in showing how to remove those IOL exchanges. I will not go much into it. Two major indications for IOL exchange as per IC is multifocal lens, where they have gross dysphotopsias and wrong power inserted. Even multifocal nowadays is come down. I think wrong IOL power this very commonly happens, may not be in small practices, but in big who have a big list, you end up inputting one IOL for the patient, the other. It normally happens, so be careful. The best is to have multiple checkpoints where you ensure that wrong IOL doesn't happen. But if it happens, Dr. Arup has shown beautifully. I have some videos, but Arup has shown very beautifully how to cut. Essentially, you have a complete cut, a partial cut and rotate, and a pie cut, and beautifully shown by Dr. Arup, and rotate and remove. So I will not go much into it. And emphasis, yes, emphasis on the type of cutting instrument, the forceps that you need to do. Piggyback IOL, off late, Sulcoflex is there. I have used in a couple of cases, but only if there are in some cases where you do have hyperopic correction where you don't have power. For example, in this case, I had put a multifocal lens for 34, beyond that it's not available. Then I went in for an additional correction. Here I put a IPCL, the ICL. Luckily that was a hydrophobic lens, and this is a hydrophilic lens. So generally they say that don't put the same materials because of interface opacification. It did work out for me. Some of them are opting for piggyback ICL or IPCL as one alternative if they have, and it does work well. Otherwise Sulcoflex is there. It's very easy, you can just go ahead. Indications is when you have a PC rent, you have some zonular dialysis, you can't remove the previous IOL for some reason, then piggyback IOL is indicated. Maybe very, very rare, but if you have such situations, I think one option is always there for you, you can consider. Limbal relaxing incisions nowadays not much. Corneal refractive surgery, yes, as a LASIK surgeon we do. In cases where I think up to 4 diopters, less than 4 diopters, I consider refractive surgeries. Usually I wait for 6 weeks, the more the better, because the stabilization occurs. Multifocals I have never done, but dioptics was a thing of the past. Nowadays not much. What you should be careful is limitations. In this age group, you have to be very careful about dry eye, surface abnormalities, and I plan for a slight undercorrection. I don't want to do emetropia, slight undercorrection 0.5. So here is a case where one patient, the other eye I had done, this is an ACIOL, he had a -4 residual, the other eye we had emetropia. So he wanted correction on this eye, was long back, ACIOL. I think PRK surface ablation easiest. If you have some facility, even any one of you can go ahead and do, just scrape the epithelium, go ahead and do, and patients are invariably very happy. Only thing is make sure that the pupil is round so that you don't have dysphotopsia post-op. The patient was doing quite well there. That is for patient with ACIOL. And this was one pseudophakic patient. I had a long IOL insertion. I went ahead and did a LASIK. He had -4, not willing for IOL explantation.